John has asked me to come and talk to you a little bit about the use of medicines during pregnancy and lactation, which by default involves kind of a discussion about treatment of mental illness, therefore kind of the course, the impact, things of this nature. The treatment of mental illness during pregnancy and lactation is often complicated by concerns about exposing the fetus and/or nursing infant to medications. Which of the following statements are accurate? Maternal depression during pregnancy has been associated with a risk for preterm delivery and low birth weight. All psychiatric medications studied to date cross the human placenta and are found in human breast milk. A history of depression and/or bipolar disorder increases the risk for the development of significant postpartum mood disturbances. All women should take supplemental folic acid during their reproductive years. And 5, all of the above. Pretty good. The answer is all of the above. I'm going to tell you a little bit about the impact of maternal depression. We're certainly going to tell you about our studies of psychiatric medicines. History is one of your biggest predictors in telling you what to do in this population, and it has been the March of Dimes and Center of Disease Control recommendation for over 2 decades that every woman in their reproductive years take supplemental folic acid. Okay? Next question. Antidepressant use throughout pregnancy has been associated with which of the following? A higher rate of cleft lip, cleft palate, transient symptoms of rapid respiration, jitteriness, and poor adaptation in the neonate following delivery, a decrease in the verbal IQ of exposed children, impaired mother-infant bonding, all of the above. Very good. There has not been a clear association with antidepressants in any specific form of birth defect. The transient neonatal symptoms I will tell you a lot more about. The decrease in verbal IQ actually comes from our data of anticonvulsant exposed children, and impaired mother-infant bonding is a consequence of maternal depression and anxiety. Okay? So, let's get started. I always give my own disclosure statement. As most of you are aware, there's been a large, flurry of activity in this area over the last few years. I have no external relationships since June of 2008, but I always give my lifetime disclosure because I do longitudinal studies. And some of the data I will present to you actually comes from children that were exposed to medicines back during a time where I may have had some of these relationships. We do our best to put your tax dollars to use. I will take as much money from the federal government to support this research as I can possibly get, and everything I do is off-label. Okay? Rather than thank people at the end, I always like to thank them at the beginning. When the Women's Health Program started in 1991, it was me and a telephone. It has grown enormously since then with expansions into genetics, child behavior follow-up, things of this nature. If any of you ever have the opportunity to hear Dr. Jeff Newport talk about bipolar disorder during pregnancy and lactation, I encourage you to do so. He is actually one of the few individuals that has been funded to do this now for over 10 years. We have a lot of external collaborations, largely because I don't believe the expertise to fully appreciate this issue is available at any single institution. And when you see some of the things about fetal activity and some of the wonderful studies being done by Catherine Monk and Janet DePatero, which look at fetal activity and uterine blood flow as predictors of neurodevelopment, it gets to be fairly obvious that we need to expand our horizons. We have started a large infertility project since it is estimated by the year 2020 that over 30% of pregnancies will involve some form of infertility intervention. Maternal age is advancing in the United States consistently. Interestingly enough, this advance has not come with an increased rate of birth defects. So, tell them what you're going to tell them, and then make sure that they've heard you. Right? We're going to talk about the course of mental illness during pregnancy and the postpartum period. We're going to help you identify high-risk groups. I'm going to tell you about the impact of the illness. And then we're going to go over what we know about the medicines. Everything that I will tell you is consistent with the American Congress of Obstetrics and Gynecology Practice Bulletin 2007, 2008, and 2010. So your colleagues in obstetrics and gynecology and midwifery should at least be familiar with what I'm going to say. A little bit of background. When we think about mood disorders in women, we think about them occurring over the reproductive life cycle. This is largely because when you look at epidemiologic data, there's very little evidence that psychiatric illnesses show gender difference prior to the onset of puberty. However, after puberty, you see a marked demarcation between males and females, particularly with respect to the risk of mood and anxiety disorders and the risk of substance abuse. Now, premenstrual mood dysphoric disorder, call it what you will, the psychiatrist's name for bad PMS. It's been around for a long time. It's been in and out of the DSM. One of the problems with this that you never really get told is the number of patients that actually have to be screened to complete a PMDD study. The largest treatment study done, published in JAMA, the Kim Yonkers Mir Steiner paper, had 267 participants. They screened over 6,000. Okay? It is a common complaint, but not a particularly common disorder. The more common situation is actually premenstrual exacerbation of a pre-existing illness, which if you want to ask me about, we can go over. We then look at pregnancy. What happens during pregnancy? Historically, we used to think things got better during pregnancy. The only thing pregnancy protects you from, rheumatoid arthritis and treatment. Okay? That's it. Postpartum gets talked about a great deal. Unfortunately, the only time we hear about it is when it's been splashed all over the news media because, unfortunately, a baby is dead, or some movie star in the twilight of her career has decided to write yet another book. Anxiety, infertility. If you are good at treating depression and anxiety, you are good at helping these women get pregnant. Okay? If you look at the conception rates in phase 3 clinical trials, back in the days of fluoxetine, the Prozac pregnancy registry did not start because they wanted to. It started because the number of women that got pregnant in their phase 3 trials. It was this experience that now led us to actually change the way we monitor conception or methods of birth control during clinical trials. Menopause, we still don't know much about it. Okay? Natural, chemical, surgical, the transition to menopause does appear to confer some risk for certain disorders, probably not as much new onset as recurrence. The burning question remains, are these all the same women? Does there exist in our population a subgroup of women who have vulnerability in mood and anxiety to fluctuations in gonadal steroids, up, down, or absent? And the answer is, to date, we don't know. We see links, but they're not as definitive as we might like. So, there are over 4 million deliveries every year in the United States. Most of them occur here in Atlanta, Georgia. We have Northside Hospital. Atlanta delivers 1% of the U.S. birth rate. Northside drops over 20,000 babies a year. Woohoo! Number one. It's a factory. Over 50% of pregnancies in the U.S. are inadvertent or unplanned conception. That is why you treat them like they are pregnant from the very first day. You will hear me say this repeatedly. Between the ages of 9 and 49, they are pregnant until proven otherwise. All a negative pregnancy test means is that they are less than 3 weeks pregnant and they will not have sex that afternoon. It is not a defense in court for bad outcome. It will not hold up. Conservatively, we are talking about over 500,000 women a year have neuropsychiatric illness predating their pregnancy. The most recent review of 8 healthcare databases showed that over 6% of pregnant women received a prescription for an antidepressant at some point during that pregnancy. Across the U.S., and certainly much higher in Canada, there is growing and uniform support for breastfeeding. There's a lot of information out there, and everybody has an opinion, whether they know anything or not. It's really quite amazing, okay? The internet has brought in this new era of just burgeoning amounts of information, and unfortunately it's very poorly referenced, if referenced at all, and typically does not reflect the actual data. The data in this area has been very steadily increasing. There has not been a lot of dramatic changes, because it takes time to accumulate this information. Very few people study pregnancy and breastfeeding on purpose. We tend to study it by accident. Okay? The group that will cause you the most trouble, your other clinicians. Why? Because they don't receive the same education about this that you do. And the other group, family members. Okay? The family members now come forward with a lot of their opinions that really can complicate what you need to do in the clinic setting. There's this ongoing debate. Are medicines good things or bad things? Think about something for a second. We worry about them being bad things. It is just as likely they are a good thing. Does prenatal exposure to the developing brain in a genetically vulnerable individual actually increase or decrease the risk of that offspring to later develop the illness carried by their parents? We don't know. It's just as likely to do one or the other. And one might argue that keeping mom and dad healthy during this period probably reduces the child's risk. So, what about illness? What does it do? Well, if you look at the studies that have been done looking at maternal depression during pregnancy, it all depends on which rating scale or diagnostic criteria you use. You heard John talking about the SCID. We've used the SCID. We've used research diagnostic criteria. The two center studies there showing those enormous rates of major depression use self-rated depression scales. How do you ferret out weight change, appetite, energy, concentration, sleep change as being related to depression or being related to the pregnancy? And the answer is, in many cases, it's not that simple. This plagues us across many conditions in women and probably in our clinical populations as well. Another example, comparing a hot flush to a panic attack. They're virtually identical. Okay? So it gets a little bit hard sometimes to know. Most of us in the area would tell you that the prevalence of major depression during pregnancy is exactly the same as it is in non-pregnant women. About anywhere from 3.5% to 6% during pregnancy will have or meet criteria, SCID criteria, for a major depressive episode. What about just stopping their medicine and saying you'll be okay? Prospective study, Lori Altshuler, Lee Cohen, and myself, 207 women enrolled, or they completed the study. They were all on antidepressants proximate to conception. Half stopped, half continued. If they stopped their antidepressant, 68% of them experienced a recurrence before they delivered. Well, the good news, that means 32% came off their antidepressant and did just fine. What concerns me more, 25% of the women who continued their antidepressant got sick. These are higher recurrence rates than you will see in any other population that has discontinued their antidepressant. For bipolar disorder, it is worse. In women that stopped their mood stabilizer proximate to conception, within 3 months of conception, 85% were ill before they delivered. Most of those episodes were depressive. So when you encounter depression during pregnancy, do not assume it is unipolar depression. It could be bipolar depression. And if you have ever taken care of an acutely manic pregnant woman, you know what I mean when I say you don't want to go there. Okay? Staying on their medicine, the women do reasonably well, only about 20% relapse. Now, part of these relapses on those that continue the medicine are probably related to a failure to manage the medicine. We know in epilepsy that as you go across pregnancy, metabolism increases, volume of distribution increases, your medicine levels drop. Please remember, the baby is not exposed to mom's dose, the baby is exposed to mom's blood level. All you do by adjusting the medicine dose is keep baby's exposure about the same and potentially keep mom well. Is it a bad depression or is it just kind of bad hair day? Well, the answer is it's just as bad as depression at any other time. Almost a third of the patients in our studies have suicidal ideation when they are depressed during pregnancy. The reason they don't act on it is because of the pregnancy. Suicide attempts during pregnancy are actually quite uncommon. However, suicide completions are very high for the rate of attempts. They tend to choose more male-related patterns, jumping, things like this, not the typical overdose. Okay? Now, should they survive pregnancy, they now enter the postpartum period, heralded by the highest risk time in a woman's life that she will enter a psychiatric hospital or become psychotic. It's been presented for a long time. Actually, it was talked about back in the days of Hippocrates. Fumes arising from the uterus make women crazy at delivery. They didn't use the word crazy, okay? Why? Well, let me introduce you to the world's perfect parasite. Without the ability of speech or movement, it can control every adult in a 50-yard radius, okay? When you have that couple coming into your office that says, you know, our marriage wasn't doing too good, we decided to have a kid, the answer is get a puppy and call an attorney, okay? This will not make your marriage better, okay? Go onto an airplane, walk down the aisle, listen to what everyone says as a new mother carries a baby down. You can hear them praying. Please, not next to me, okay? The blues, so common we call it normal. Any complaint within that 10-day window we think about as the blues, but as a good rule of thumb, any complaint outside that 10 days is not the blues, okay? Postpartum depression, very much a wastebasket term, affects about 10% of adult women, a little bit higher in your teenagers and adolescent mothers. It can be quite severe. The majority of these women have onset by 6 weeks postpartum. Whether or not the postpartum modifier will be continued within the DSM system long term is unknown. It has been removed, my understanding, for DSM-5. It was there for DSM-4. Postpartum psychosis, absolutely a medical emergency. There is no reason not to hospitalize. It carries with it an 8% risk of infanticide. Most of those cases are probably bipolar, probably accounting for why lithium works so well in postpartum psychosis. The biggest risk factor you have for postpartum illness is history. It likes to come back. It likes to run in families. If they have had it with the first child, there's a 50% chance that if you do nothing, they will have it with the second child. Major depression during pregnancy, another big risk factor, or is it simply a continuation? Are we identifying women in the postpartum period that were actually depressed during pregnancy and it simply has continued? We don't know for sure. Most of our prospective data says yes, that in fact the recurrent postpartum episodes began during pregnancy. Okay? De novo, new onset, never been sick before postpartum illness accounts for less than 20% of all cases. You can identify them by history before they ever deliver. For bipolar disorder, it is worse. Treated or not treated, they are at incredible risk in the postpartum period. We don't know how much of this may be due to the profound sleep changes that you often get in the postpartum period. We don't know if it's related to what they've done with their medicines. We're trying to find out. The take home is they don't do well. And most of the episodes are depressive. So when you encounter depression both during pregnancy and now the postpartum period, do not assume it is unipolar depression. If you hit them with the antidepressant and their sleep pattern falls apart and they get agitated, bet your money that you just found bipolar disorder. Is it a bad thing? Maternal psychiatric illness is the highest contributor to maternal mortality in the postpartum period in North America, Australia, Quebec, and in the 2 European countries it's been looked at. It exceeds infection. Thoughts of harming the infant get talked about a lot, but the actual act is quite rare. But actually, thoughts of harming our children are ubiquitous, right? Think of nursery rhymes. Who puts a baby in a tree? Who do you think Humpty Dumpty was? Okay? We act out on our children in our nursery rhymes because we don't really want to hurt them, okay? When you encounter a patient who's having a difficult time understanding that there's actually some limit there, or they're genuinely concerned that they might do that, this is where I go by the old axiom. When a house is on fire, your first task is to put out the fire, not to rewire the house. An acutely ill postpartum woman with thoughts of harming the child is not a candidate for insight-oriented psychotherapy, okay? You will open Pandora's box, and very few people have the skill to close it. Stabilize. We can come back to look at it later, okay? So, in summary, Eating disorders, mild to moderate substance abuse, and maybe panic gets better during pregnancy. Only mild substance abuse gets better postpartum, and that's typically if they're breastfeeding. Obsessive compulsive disorder gets worse both in pregnancy and postpartum. Depression, bipolar disorder, plus minus. Really don't have a good feel for a good predictor of who's going to do well and who's not going to do well, on or off medicines. But the only things that improve in pregnancy are eating disorders, and they tend to reemerge with a vengeance postpartum. Does it do bad things? Well, if it didn't do bad things, we wouldn't really worry about treating it, okay? But the bad things actually have an older and more established literature than the medicines do, but oftentimes are left out of the discussion in medicine-related papers. If mom is sick, she will be non-compliant with her prenatal care. She'll be more likely to abuse cigarettes, alcohol, drugs. It will have a massive effect on the family and family stability. They're at greater risk for postpartum illness, greater risk for preterm labor, premature delivery, low birth weight, small for gestational age. You run through the list. Now at first pass you go, okay, so the kid's a little smaller. Low birth weight is not a good thing. In fact, and I'll tell you a little bit more about that, I'm going to introduce the concept of intrauterine programming. If you want to avoid anything for your patient, it's low birth weight. Okay? We then follow these children up. They don't orient as well. Their motor skills don't develop as fast, and they show EEG asymmetries. It's right hypofrontality. Okay? They don't orient as well, and they tend to be more withdrawn and less interactive to their environment on our scores. Okay. Look at them as we look at further down the road. We see ADHD, aggression and conduct disorders, and childhood anxiety. A little further out, you see elevated cortisol and attention deficits. This is a prospective study by Marilyn Essex lasting over 22 years. Increased violence in 10, 11, and 12-year-olds. Higher rates of conduct disorder and violent behavior. In fact, the only psychiatric condition in the parents that was a stronger predictor than illness in the postpartum period was paternal sociopathy. Substance abuse didn't even beat it. This is a bad thing. The question is, does this include prematurity? In these particular studies, they did not look at obstetrical outcome outside of the model. They put it in as a cofactor, and then they looked at what filtered out, and what filtered out and came to the top every time was whether or not mom was sick. Okay? It's kind of like our studies when we looked at whether or not mom discontinued her medicine. The medicines had such a strong impact on driving the outcome that everything else just fell out of your equation. Same thing happens here. Prematurity does not predict violence if mom is well. But if mom is ill, prematurity doesn't even make the list because the ill effect is so great. It's one of the problems you have in logistical models when you've got multiple variables going into the model. It's very hard to tease out one from another if one is incredibly strong at driving the whole model. The other thing it does, they take other things. This is a study by Dr. Newport and Dr. Long with our group. And what he asked was a simple question. We all worry about psychiatric medicines, but do women with depression and anxiety actually take other things during pregnancy? And the answer is absolutely. A depressed woman is more likely to take an antiemetic, anti-nausea medicines. Anyone know what the most common anti-nausea medicine is? Phenergan, promethazine, and aliphatic phenothiazine related to Thorazine. You all know we developed Thorazine, chlorpromazine to originally treat nausea during pregnancy. Or nausea during anesthesia, actually. It was then used in pregnancy. We won't go there right now. So anyway, they take a lot of other things. They take sleep medicines. Zolpidem tartrate is given out like M&Ms to pregnant women. Pain medicines, the use of opiate pain medicines during pregnancy. Higher rates of sciatica, pubic symphysis discomfort. So their illness shows up in a variety of somatic complaints that then are naturally medicated by the OB. So you're giving more exposures to the kid. The study that drove it home to me, this is a prospective study conducted here at Emory. These women were followed all the way through pregnancy, seen every 4 to 6 weeks. Their husbands were, we know everything about them. I don't know if we could have done any better. At 6 months of age, the child is brought into the lab. During that time, we stress the child. Okay? We collect salivary cortisol, behavioral measures throughout this period. The first infant stressor task is the noise burst task. Set a noise off behind the baby's head, they jerk. Now, as I see Dr. Johns here, who was a resident under my leadership, he will tell you that this would never satisfy my sadistic tendencies. So we did this. This is the arm restraint still face paradigm. You hold a baby's arms straight and at their side and stare at them with an emotionless face. You got about 6 seconds before the normal baby gets really pissed off. Okay? We had an entire set of babies that just stared back at us. You see that camera in the back? That's not watching the baby. That's watching my graduate student. It's watching my graduate student to keep measure of whether or not my graduate student gave a nonverbal cue to the mother who's sitting right over here. The moms can call no joy at any time. Means stop. Okay? We found that our graduate students would get so distressed by the baby being distressed, and the mothers would just sit there. And they all belonged to the same group. When you looked at their salivary cortisols in the baby, what you see here is a dramatic increase in baby's cortisol response to the stressor task if mom was ill and not treated. That's the one way over there, the purple one. Huge increase. These kids are physiologically hyperactive, yet behaviorally inhibited, and mother seems disconnected. This falls into the thing I talked about, intrauterine programming. This is why birth weight is important. Barker hypothesis, put forth many years ago, now over 100 studies on cardiovascular disease. Low birth weight is one of your strongest predictors to develop adult cardiovascular disease. Well, actually, I think I got it here. Yeah. Adult cardiovascular disease, type 2 diabetes, osteoporosis, depression, schizophrenia. Low birth weight is not a benign event. If you have a way to intervene and get a normal birth weight baby, you're doing preventative health care for that child. Studies that we do, does what happened to mom in pregnancy happen to baby? Cortisol and ACTH, people have debated whether or not they cross the placenta, so we looked at cord blood and mom's blood at delivery. In other words, we wanted to know if mom was stressed, did baby show the same stress? We're now doing fetal activity, uterine blood flow, but basically these studies showed that yes, mom's ACTH, mom's cortisol directly correlate with babies very strongly. What happens to mom happens to baby. Well, if illness can do things like this, you'd like to be able to treat it. Okay? The good news is we've got a lot of treatment options. The bad news is some of those treatment options have almost no data whatsoever. Psychotherapy sounds like a really good, viable option that if their insurance or if they can afford it would be a good candidate. We just don't have a lot of studies of psychotherapy in pregnancy. The studies we do have show that it works. The problem with this is, how many states Medicaid pays for psychotherapy? ECT. How many of you in here would be willing to throw a switch on a pregnant lady? I've done it. Makes everyone real nervous. Baby does not seize. ECT in pregnancy dates back to 1932. Okay? Left lateral decubitus position. Minimize your anticholinergics. They are in fact teratogenic. Okay? Light therapy, great idea. Probably won't work here in Atlanta. Okay? But we only have one study, non-controlled. We need more studies. Transcranial magnetic stim, very viable alternative. We started the study, had trouble with the volume, the number of visits people had to go to because most of our women have other kids. So the time required became a real issue. Exercise therapy. It's a nice model out now. Madhukar Trivedi's work and others looking at the role of exercise in improving mood. Perfect thing to be tried in pregnancy. Hasn't been done yet. Alternative and complementary medicine. I actually have patients that do a lot of this, but I want you to hear this very clearly. Natural does not mean safe. Usually what natural means is no data. Okay? And when you buy something from a GNC food store that has not been screened by the FDA, you have no idea of the quality of control that has gone into that. For all we know, someone made it in their garage. You don't have to look any further than the tryptophan experience for that one. An impurity got in the coating of the tablet from a generic company and we killed 18 people. It resulted in tryptophan being pulled from the market in every form for 4.5 years, till they tracked it down. The FDA is an anal retentive group of Huns, but they are good at screening, far better than most other countries' screening services when it comes to reproductive safety. We only use prescription prenatals. We do not use over-the-counters. When you look at a meta-analysis of the treatment, and again, the problem here is that the therapies don't show up as well because we don't have a lot of data, everything leads back to medicine. And I think that's unfortunate because it's misleading. It leads back to medicine because that's where you have the data, not because the others don't necessarily work. Okay? Well, if you use medicines, these are the current pregnancy categories from the FDA. They're currently under revision. The revisions, at least in my opinion, are not clinically as helpful as I'd like them to be. Do we use this to treat pregnant women? The answer is no. The reason is it does not correlate as well with birth defects as it does the age of the medicine. The older you are, the more likely you are to move down this list. Once you move down this list, you will never move back. If you require giving a Category A medicine to a pregnant woman, you can give levothyroxine, Synthroid, and tap water, depending on where you live. Okay? There just aren't controlled studies in pregnancy, and there are not going to be any. And sometimes these category changes don't make sense. For example, zolpidem tartrate as immediate release was a B. When the controlled release came out, it became a C. There was no data. Bupropion spent its entire life as a B. Recently was changed to a C. Because if you roll it up in a ball and drop it on a pregnant rabbit at 100 mg per kilogram body weight, you got thin pelvic bones. Okay, so if your patients overdose daily on bupropion, it's bad for pregnancy. It just doesn't fit. The only Category X medicines in psychiatry are the benzodiazepine sedative hypnotics. There's not a single confirmed birth defect on them. I think this is what you'll see in the PDR. Use in pregnancy is not recommended unless the potential benefits justify the potential risks. Newsflash, you're not supposed to prescribe to anyone unless that's true. Okay? It's hand washing. Dr. Scow, the author of the Lithium Registry, says it best. When manufacturers and official agencies warn against drug treatment during pregnancy, their warnings serve to protect themselves and are of little use to us. He never intended for lithium not to be used in pregnancy. He simply wanted us to know the risks. What I do for a living, I want to know how much gets to baby and what baby does with it. We've been looking at amniotic fluid, we've been looking at placental tissue, we've been looking at cord blood at delivery. The take-home message is simple. Every medicine I've looked at can be found in amniotic fluid. Every medicine I've looked at can be found in human cord blood. That means that baby got it. If anyone tries to convince you that the baby is not exposed to a medicine, walk away. They do not know what they are talking about. Our medicines are designed to get into the brain, which has a much tighter barrier than the uterine placental junction. Complicated slide, just to put it in perspective for you. If you are at that red line, it means baby's blood at delivery equals mom's blood concentration. You will notice that for all the mood stabilizers, except the antipsychotics, the mood stabilizers, baby's blood level is either equal to or greater than mom's at delivery. And we actually started using this clinically, and I'll show you how in a moment. The antipsychotics, a little bit lower. The antidepressants, lower, but all over the board. Lot of variability. Very little relationship to dose. Maternal dose did not reliably predict what baby's exposure was. Complicated, just want to show you this. I always show these and everyone kind of looks at me with this glazed over look. So this wasn't good enough for me, so we did animal studies. We dropped osmotic mini pumps in laboratory, pregnant laboratory rats to study this. We used osmotic mini pumps because if you give single daily dose injections, you get a curve that looks like the dark blue line. Okay? Now think about this for a second. Everything you've been taught about neuroscience and antidepressants gave the antidepressant to the laboratory animal with that model. They didn't use osmotic mini pumps. So everything you've been taught about neurochemistry is based on toxicity, followed by elimination, followed by toxicity, followed by elimination. It's probably why a lot of stuff doesn't line up. We use mini pumps, lock them into the therapeutic range, We did the same thing here for fluoxetine, because the fluoxetine half-life in a rat ain't 24 hours. Anyone ever want to guess what the valproic acid half-life in a rat is? 18 minutes. Yeah. So once a day injections, even twice a day. You give an injection every 30 minutes, it might work. Okay? When we did this, we then looked at the pup brains to see if the medicine was there. What we found was that enough got across the placenta to block every single serotonin transporter in that brain. It went in, it hit its target, but then by postnatal day 3, it was completely gone. By day 7, it was still gone. We couldn't find a footprint. We then follow those rats out to adulthood, be it the SERT transporter, the norepi transporter, or the dopamine transporter. We cannot find long-lasting, sustained effect on the number and location of these transporters from medicines during pregnancy. Now, should this surprise us? Not really, because that's why when your patients come off their antidepressant, they can get depressed again, because the medicine doesn't induce a permanent change. It works while you take it, it does what it does while you take it, and then when you